Hello, wonderful staff at the Northwest Kidney Center with a nod to our flagship unit in Kent as well as the surrounding units. Today we're going to talk about nutrition in dialysis patients, specifically focusing on the monthly blood test known as albumin. Albumin is the major protein present in the blood, and it's often used as a marker of assessing nutritional status in dialysis patients. And of course, nutritional status and support is really important to the health and longevity of our dialysis patients. This talk, as usual, has three objectives. I want you to know what albumin is and why we measure it. We'll review studies looking at the clinical impact of protein supplementation during dialysis, and I want you to recognize the limitations of using albumin as a marker of nutritional status. This is a quote from a philosopher in the Middle Ages named Moses Maimonides. Basically, he was a Sephardic rabbi, philosopher, became one of the most prolific and influential Torah scholars of the Middle Ages. And he said, "The rule laid down by the great masters of medicine is that anything that might be cured with food, i.e. diet, should not be treated by other means." In other words, there's a lot that we can do in taking care of our patients that can be managed with diet. Let's begin with a discussion regarding albumin. So you could just look around our dialysis unit and instantly recognize that malnutrition is a major problem among dialysis patients. And there are a lot of reasons for this. I mean, sick people don't often eat as much as they need. They tend to be very catabolic in their illness. Access to nutritious food is often limited and it's expensive. Some people can't get to the store, or some people don't have the ability to cook for themselves. And dialysis in chronic illness leads to a hypercatabolic state. So dialysis patients often lose weight because they are so catabolic, constantly burning calories. How can we assess the nutritional status of our dialysis patients? Well, essentially, this should be based on a combination of clinical parameters as well as biophysical and biochemical parameters like laboratories. We can measure their body mass index. We can measure change in their weight over time. We can measure skin fold thickness or hip-waist ratio on physical examination. Somewhat arduous but useful is a food diary or a food frequency questionnaire. But the easiest one, and the one that we rely most heavily on, is a monthly measurement of a blood test called albumin. This is probably the most convenient tool to measure nutritional status, although it has some major limitations which we will discuss later. The term albumin derives from the Latin word albumen, which means dried egg whites. It is a negatively charged, water-soluble protein in the blood. It's produced by the liver, and it constitutes about 60% of the proteins in the blood. So it's the major protein in the blood. And if you're interested in biochemistry, it's distinguished from other proteins in the blood because albumin is not glycosylated, meaning that there are no sugar molecules that get added to albumin after it is made. That said, albumin has some limitations as a nutritional marker. For example, there is a condition known as marasmus. Marasmus is characterized by severe loss of lean and fat mass. It results from prolonged deficiency of both calories and protein, and it gives you the image that we see in this picture, someone who's clearly wasting away, and it's often seen in third world countries in the setting of a famine. Although people with marasmus typically manifest the skeletal appearance of someone who's wasting away, it's common for their serum albumin levels to remain normal. So in other words, malnutrition, even when life-threatening, is not always sufficient to cause a low serum albumin level or hypoalbuminemia. Anorexia nervosa is something that we see in this country in which people starve themselves, typically because of a dysmorphic body image. These people also typically don't have a low albumin level, at least until the very late stage. Interesting, there's also a condition called analbuminemia. It is a genetically inherited metabolic defect characterized by impaired synthesis of serum albumin. Even though they don't make albumin, this tends to be a benign condition. So these people are not malnourished. The significance of all this is that high albumin does not always mean that someone is not malnourished, and similarly, low albumin does not always indicate malnutrition. All right, now let's talk about albumin in dialysis patients. So what is the usual range of serum albumin in a dialysis patient? Well, we know that for the normal population, an albumin concentration of 4.0 grams per deciliter or above is normal. What about patients who are just starting dialysis? These are so-called incident dialysis patients. It was a large study of almost 37,000 incident or new dialysis patients, and they were found to have a mean serum albumin level of 3.57 grams per deciliter. What about prevalent dialysis patients? In other words, dialysis patients who have been on dialysis for a while. There was a study published by Yi in 2017 that reported a mean serum albumin in prevalent dialysis patients of around 3.5 grams per deciliter. In May of 2017, about 19% of hemodialysis patients and 44% of peritoneal dialysis patients were hypoalbuminemic with levels below 3.5. So low albumin levels are very common in the dialysis population. So why do so many dialysis patients have low serum albumin levels? There are many reasons. The main one is because of inflammation and illness. Turns out that albumin is made by the liver and is what's called a negative acute phase reactant, meaning that the production of albumin falls in the setting of illness. And of course, dialysis patients are almost ill by definition. I mean, they've got kidney failure, they've got all the comorbidities associated with that, and all that contributes to inflammation or chronic illness, and that sends a chemical message to the liver to produce less albumin. So in summary, the predominant cause of low albumin dialysis patients is a decrease in the albumin synthesis rate. But dialysis patients also can lose albumin. During dialysis treatments, we uniformly use what are called high flux dialyzers, which have large pore sizes and increased permeability, which is good for removing waste products. But at the same time as removing waste products, we also remove albumin with dialysis. We can remove typically between 5 and 10 grams of protein per treatment. We don't exactly know the impact of such chronic loss of albumin over time on patient outcomes, but it can't be good. Albumin loss of more than 3.4 grams with a high permeable membranes has been associated with lower serum albumin levels within 2 to 3 weeks after just starting treatment, suggesting that albumin loss may be too high to be compensated for by an increase in albumin synthesis. So if albumin is really not a great marker of nutritional status, why do we check it every month, and what is the clinical benefit of checking it at all? Well, it turns out that low albumin is a good marker for increased risk of clinical complications. Phrased another way, dialysis patients with low albumin do not do well clinically, and they have a higher rates of hospitalization and mortality. So if you have a dialysis patient who has a low albumin, that is the person who needs more attention in order to prevent complications. Among these complications include an increased rate of hospitalization. A study by Alpa Kiesler published in 1999, observational format, looked at 73 adult dialysis patients from a single outpatient center in the United States who had been on dialysis for at least 3 months and were followed for 15 months. When assessed as a single variable, albumin correlated strongly with an increased hospitalization rate. People who had a normal serum albumin of greater than 4.1 had a 17% chance of being hospitalized in 15 months. Those who had a slightly low albumin between 3.9 and 4.1 had a 24% rate of hospitalization. Between 3.9 and 3.7, 27% risk of hospitalization. And if you had an albumin below 3.7, you had a 43% chance of being hospitalized in the next 15 months. So very strong correlation. That said, if you perform what's called a multivariate or multiple variable analysis that included multiple variables, such as an inflammatory protein called C-reactive protein, as well as something called bioimpedance, as well as albumin, then the albumin by itself no longer correlated with hospitalization risk, suggesting that it's not nutrition that leads to an increase in hospitalization rate. It is the underlying medical problems that are leading to inflammation that are reducing albumin production. Low albumin rates also predict longer hospitalizations, which incur greater expenses. So the lower the serum albumin, the longer dialysis patients are likely to be hospitalized. This is a study by Rocco in 1996. It found that the average dialysis patient spends 11.9 days in the hospital per year, but those with an albumin of less than 3.5 spend on average almost 19 days in the hospital per year, resulting in nearly twice the cost of hospitalization. Dialysis patients with low serum albumin also have an increased risk of mortality. The relationship between albumin and mortality in long-term dialysis patients was first described by Goldwasser and colleagues in 1993. This is a prospective study of 184 dialysis patients. And the study sought to find a relationship between albumin and mortality, basically between biochemical markers and mortality risk. And what they found was in 108 patients who had been on dialysis for more than 12 months, a serum albumin of less than 3.5 was the strongest predictor of mortality. Specifically, serum albumins below 3.5 were associated with a 7-fold increased risk in mortality compared to those with albumin levels above 3.5 grams per deciliter. Another study that looked at the relationship between albumin levels and mortality was published by Locatelli in 2009. It's a randomized controlled trial of 647 dialysis patients. It was a 2x2 study, so patients were randomized to either a high or low flux dialyzer, but then also stratified by high or low albumin, above or less than 4, and the primary outcome was mortality. There were 162 deaths, and 132 of them occurred in the patients with an albumin of less than 4. So the mortality risk was 27% for those with an albumin of less than 4 grams per deciliter compared to only 19% for those with albumin greater than 4 grams per deciliter. Turns out the dialyzer type had no impact on mortality, and this has been demonstrated in other studies as well. Another study that looked at the relationship between low albumin and mortality was published by Lowry in 1990. Observational study of 12,000 dialysis patients, and they found that the adjusted relative risk of death increased as serum albumin fell below the normal range. So for example, the relative risk of death for someone with an albumin between 3.5 and 4 was 2.2, so meaning that they had 2.2 times the risk of dying as someone who had an albumin greater than 4. It was 6.7 for someone who had an albumin between 3 and 3.5. It was 15.3, so 15-fold higher risk of mortality for someone who has an albumin between 2.5 and 3.0. And if you had an albumin of less than 2.5, your risk of mortality was 19 times higher than a dialysis patient who had an albumin between 4 and 4.5. And the last study I'll show you that looks at the relationship between albumin and mortality looked not so much at a single point in albumin, but the change in albumin over time. Basically asking the question, hey, if you start out with an albumin of 3.5 and you go to 3.9, does that person do the same, better, or worse than someone who, say, started out with an albumin of 3.9 and then went down to 3.5? So, does the direction of change in albumin impact mortality? And what they found was yes, the change in albumin over time is also a predictor of all-cause and cardiovascular death. Actually, it's probably a little bit better predictor than just a fixed measurement of serum albumin at the start of the study. So increase in serum albumin over time is associated with better survival, is what you'd expect. Based on this study, the authors conclude that if you could raise serum albumin to levels of 3.8 or above, you could reduce the number of hemodialysis deaths in the United States by 10,000 annually. But this involves a major assumption. Again, we've been looking at associations, and they are not necessarily the same thing as causation. So just because we know that low serum albumin is associated with mortality doesn't mean that if we raise the serum albumin, we can necessarily reduce mortality. I'll phrase it another way. So we know that there is a strong association between low albumin and mortality. Now, if the low albumin is associated with increased mortality, does it mean that a low albumin causes increased mortality? The answer is no, because of something called confounding. Confounding occurs when an association between a predictor of interest, like low albumin, and an outcome variable like mortality can alternatively be explained by another variable. In other words, something else is going on. It's not a direct causal relationship between albumin and mortality. I'll give you another example of confounding. In third world countries, the more television sets a family owns, the greater their longevity. So if you own 6 televisions, you are likely to live longer than a family that owns just 1 television. Could we lengthen the lives of people in Rwanda by shipping them more televisions? In other words, is it the televisions that give people longevity, or is it something else? And the obvious answer is that it is something else, that shipping televisions to Rwanda would not improve longevity. The confounder here is wealth. Wealthy nations can afford more television sets, and that is a surrogate for being able to afford better nutrition, clean water, better access to health care, and these resources improve longevity. So diagrammatically, you can see that wealth allows you to buy more television sets, and wealth gives you access to better nutrition and all the other factors that can improve your longevity. So it's not the televisions that extend your life, it is financial resources. And the same is true for the relationship between albumin and mortality. There is concern that low albumin it's a good surrogate, but not necessarily the cause of increased hospitalizations or mortality because of the presence of confounders. So again, we've got a relationship, low albumin leading to mortality, but likely it's other variables, other confounders that alternatively and more precisely account for the relationship. So that could be just chronic illness, maybe resources, access to food, or access to medicines, and there are probably other unidentified potential confounders in this relationship as well. That said, the National Kidney Foundation KDOQI, or Kidney Dialysis Outcome Quality Initiative guidelines recommend that serum albumin levels in dialysis patients be maintained at a level of 4 grams per deciliter or above. So the idea is, if we can raise albumin levels in dialysis patients, can we improve their clinical outcomes? For example, can we reduce their rates of hospitalization and mortality? Unfortunately, there are not a lot of high-quality studies that have been published to answer this question, but we will review what's available. Chu published a retrospective cohort study from 2006 to 2008 of 470 hemodialysis patients in the Fresenius system who were at high risk for protein energy wasting or malnutrition. They had a serum albumin below 3.8 grams per deciliter as a 2-month average. 276 patients were willing to be enrolled, and they were given 1 can of Ensure per day. 194 patients refused to participate or were not felt to be appropriate candidates for the study. This is a box plot that shows what happens to the serum albumin levels over time in months, and it turns out that by giving people protein supplements in the form of Ensure during dialysis, it really translated into a very minimal increase in serum albumin, basically like 0.1 grams per deciliter, hardly anything. That said, those who received the protein supplements had lower rates of hospitalization. So this is a Kaplan-Meier curve that looks at the probability of not being hospitalized. The line on top is the supplement group, and the line on bottom are the people who did not receive the Ensure supplements. And the probability of not being hospitalized was greater for those who received supplements. This is another Kaplan-Meier curve that shows the probability of survival over time in days. The dashed line is the supplement group. The solid line is those who did not receive supplements. It turned out that the survival probability was greater for those who received supplements. Now again, this is a non-randomized trial. So the study design has some limitations. That said, people got pretty excited. Giving a can of Ensure on dialysis is a low-cost intervention if it translates into better survival. This is one of the studies that influenced the Northwest Kidney Center's decision to give protein supplements on dialysis. Well, if supplements are good, maybe supplements plus exercise or something to stimulate, muscle growth would be even better. So this is a randomized controlled trial. Patients were given a 6-month interdialytic cycling program, so they got to pedal on a little bicycle, combined with nutritional support, physical functioning, and looking at quality of life. There were 21 patients with protein energy wasting with a mean age of 70. 10 were randomized to nutrition plus exercise, and 11 just got nutrition alone. Unfortunately, there was no significant difference between the two groups with respect to labs, body mass index, or activity improvement. So what about administering something called intradialytic parenteral nutrition, or IDPN? This is an intravenous protein preparation administered during dialysis, and there are lots of studies over the last few decades that have demonstrated this is a very safe thing to do, and that IDPN increases serum albumin. But unfortunately, there are no studies that have convincingly shown an improvement in hard clinical endpoints, such as reduction in mortality. And that's because there are all sorts of study limitations. Most of these studies had small numbers of patients, did not have controls, included patients who did not have protein energy wasting and were therefore unlikely to derive benefit from protein supplementation, didn't control for oral intake of protein supplementation. Most of the studies were non-randomized and of short duration. So we just don't have the data to support this particular intervention, which unfortunately is a lot more expensive than giving someone a can of Ensure. So what do we know about IDPN? Well, the most we can say is that IDPN successfully raises serum albumin in dialysis patients. This has been shown by several studies, including this one by Kittis Kulnam in 2022, is a prospective randomized controlled trial of 38 maintenance hemodialysis patients who were found to have protein energy wasting and were unable to tolerate oral protein intake. They were randomly assigned to either IDPN versus a control group. The IDPN group received this fish oil-based parenteral nutrition that was infused during dialysis for 3 months. The control group, in comparison, received intensive dietary counseling once weekly for 3 months, and both groups were then followed for an additional 3 months after the intervention. Mean age of the patients was 68 years. And after 3 months, the serum albumin was significantly higher in the IDPN group compared to controls. But again, it didn't translate into any obvious clinical outcome that was favorable, such as increased muscle mass or strength, any change in volume status, or glycemic control. So conclusion is IDPN is superior to dietary counseling in raising serum albumin, but again, does this necessarily translate into better clinical outcomes? It did not appear so in this study. A systematic review of IDPN studies in dialysis patients was published in July of 2009. The authors determined essentially that clinical data remains insufficient to demonstrate a net benefit or net harm of IDPN in dialysis patients. Several of the studies did show that IDPN successfully raises serum albumin on average by about 0.4 grams per deciliter. Okay, what have we learned today? First, most hemodialysis patients have serum albumin levels below the recommended range of 4 grams per deciliter by the KDOQI guidelines. Serum albumin less than 4 is associated with an increased risk of mortality and a higher hospitalization rate. The use of higher flux dialyzers, also known as protein-leaking membranes, is associated with an increased clearance of both middle and large molecules, including proteins. So there is protein loss during the dialysis procedure. Several observational studies have demonstrated an association between low albumin levels and increased mortality, but remember that association is not the same as causation. Observational studies suggest an improvement in mortality with protein supplementation on dialysis. Again, that's why we do it. But remember that these are observational studies. They are not controlled. And finally, there are no high-quality randomized controlled trials that demonstrate raising albumin levels through supplementation on dialysis improves mortality. Okay, time to see if you were paying attention. Question number 1, what is the target albumin level for a dialysis patient as recommended by the National Kidney Foundation Kedoki Society? That's right, 4 grams per deciliter or above. Excellent. Next question, low albumin level is associated with what in dialysis patients? That's right, increased hospitalization and mortality rates. Next question, true or false? Observational studies suggest an improvement in clinical outcomes associated with albumin supplementation during dialysis. That's correct, it's true, but remember that observational studies just allow you to describe an association between 2 variables, not necessarily the same thing as causation. Next question, true or false? Administration of protein supplementation to dialysis patients during the procedure raises albumin levels. That's right. So that's pretty much all we can say from the available studies is that when you give protein supplements, particularly in the intravenous preparation, the IDPN, we can successfully raise serum albumin levels. The oral preparations like the protein drinks that we give our patients on dialysis, they minimally raise albumin, but they do raise albumin levels. Next question, does the administration of intradialytic parenteral nutrition, so the intravenous preparation of protein during dialysis, improve mortality? The answer is false. Okay, so we know that IDPN raises albumin levels, but there's no study to suggest that it reduces mortality. Okay, this concludes the June 2024 monthly in-service for the Northwest Kidney Center. Thank you so much for your attention. Thank you for the wonderful care of our patients. Signing out until next month. Have a great start to your summer. Bye-bye.